Well, let's turn now to the challenges and the uncertainties that the various treatment options throw up. Let me come back to you, Adam, to Dr. Ashaka. Just outline for everyone watching this what you believe are the benefit, the risks, and the limitations of revision surgery.
So the clear advantages are that if you have a clear disease correlate, that you can access directly the tissue, for instance, in the paranasal sinuses, in the frontal, using powered and navigated instrumentation. And you can use this kind of treatment as an immunoablative procedure, meaning that you reduce the amount of inflamed tissue in the nose, directly where the situation occurs. This means also for the time after the surgery that you have, when things heal off, a potential of disease modification, though we all know that in those patients where we had already one surgery, this kind of approach may be too optimistic. The potential risks that can occur are also very familiar for us. The eyes and also the skull base are very near, so the responsible surgeons and experienced surgeons will either use navigation or will have extensive experience with the anatomical landmarks and situations there that can be sometimes jeopardized by previous surgery as well. And the limitations, let's be very clear, the more often you have done revision surgery, the less likely it is that you really are going to change things for long term. In particular, if you aim for disease modification using approaches like reboot surgery, you should be really, really humble with your own estimates when it comes to your own surgical skills. On the other hand, what you have at stake is that the patient may need much less systemic treatment for a considerable time, and may have very easy access to the paranasal sinuses. So I think revision surgery has a lot of chances, but you have to choose the right patients.
And Professor Han, is there anything you would like to add to that incredibly comprehensive answer about revision surgery?
I think Professor Shaka did a really good job kind of explaining it, but I'd like to add a couple of points. So, when he said that the benefit of sinus surgery is kind of decreasing the inflammation, in a way you're resetting the inflammation, you're getting rid of it all so that you can allow better treatment, better efficacy of the medical treatment. And one of the limitations that I think a lot of people, or a lot of misunderstanding, is that they don't think that nasal polyp is a chronic disease. It's a chronic disease, just like diabetes, just like hypertension. So, a lot of people think that by doing surgery, you get cured of the nasal polyp, but that's not true. Surgery is just one big step in trying to decrease the inflammation so that the medicine can work, but you still need to be on medicine. So, revision sinus surgery never cures nasal polyp. It's just one big step in allowing the medical treatment to work much better.
Okay, and Professor Fokkens, let's do the same if we can with biologics. For you, outline for everyone watching this the benefits, the risks, and indeed the limitations of biologics themselves.
Of course, biologics only work if there is type 2 inflammation. So not all polyps have type 2 inflammation. In the US, in Europe, most severe patients have type 2 inflammation, but definitely not all. In Asia, for example, it's about half. So type 2 inflammation is a prerequisite to have a biological working. So that's one important thing. Another important thing is that not all biologics are the same. Some biologics work better in some patients than others. Some biologics work better in certain diseases than others. We have patients with severe asthma where the biologic works very well for the asthma, not so well for the chronic rhinosinusitis with nasal polyps, and vice versa. So that is something we still have to learn. And we are in a learning period of a limited number of years now to really understand which biologic is perfect for a certain patient. And we heard that already from our patients, saying, I now start to have my fourth biologic. Of course, that's not what we want. We want to directly have the proper treatment for that specific patient. But now it's still very often a matter of trial and error.
Sorry to interject, but Joachim, you spoke about biologics as well earlier on. Any views there about the limitations, the risks, the involvement when you start patients on biologics?
Well, the main limitation, I think, following what Wytske said, is that we try to treat patients in a new way with different biologics that target different targets, different inflammatory targets. But we don't know yet which kind of patients should be treated in each with these different targets. That is when we have the magical word or the holy grail. That is the biomarker. We are trying to use and learning and studying new biomarkers. We have, for example, eosinophilia in the nose or in the blood. That is a marker of mainly severity and global inflammation, general systemic inflammation. But we don't have good markers that predict the success of treatment. This is the holy grail at this moment, to find markers, even in tissue, even in blood, that will predict that this specific drug will be or will have the maximum efficacy in this group of patients. And although we mark a guideline as a highway where most of the knowledge goes straight ahead, we have to individualize. That is where we are going for personalized medicine, looking to biomarkers that help us to learn and to show the patient what is the best treatment for them.
So Joachim, just staying with you, just in terms of when you start, you talk about biomarkers and so on, but just in terms of the biologics, how much uncertainty is there in your own head, indeed in your clinical practice, when you start someone on a biologic? How much, what are the parameters of uncertainty in the way that they are likely or unlikely to respond?
Actually, there is a big uncertainty. I mean, we decide to give one drug or the other depending on some issues. For example, if there is a lot of eosinophils, the disease is very eosinophilic, more than 1,000 and so on, maybe we will go directly to give a drug that is anti-eosinophilic. And we will prevent maybe of giving other drugs that could increase the eosinophil instead of down-regulate them. I mean, I think that still we need a lot of research to be done to make a clear definition or a clear indication of which antibiotic, which biologic should go in a specific patients. In asthma is different because at least they have the allergic asthma and they have one specific drug that is anti-IgE, anti-allergic. But this is not the case of, this is not demonstrated, the case of chronic rhinosinusitis with nasal polyps.
And Adam, Dr. Schaake, just for you, that level of uncertainty when you use biologics, anything that you'd like to add about those parameters?
If you've asked me 2 years ago, I would have been optimistic. To be very fair, my personal impression is that there is a reason why we have these broad error bars in the clinical studies. And though we do our best for endophenotyping our patients as good as we can with the markers we have available, we may have not fully understood those patients who will show optimal response for the 3 different drugs available at present. I think what is very clear, and this is something we have learned also from EPOS 2020, is we should not go for non-type 2 disease. And this is very important. So if we don't have any evidence of type 2 disease, we should not switch off our brains and just do it. we should be careful, because we reduce the risk, we reduce the likelihood that we will have a success. And in all the other cases, I would follow the lead of Professor Muyol with regards to eosinophilia, but also for total IgE. But it's not very clear. It is not very clear yet.
Okay. And Professor Fokkens, just coming back to surgery, what level of uncertainty do you have before you operate?
Well, the first surgery is quite clear. We want to remove as much as possible of the inflammatory tissue and open up the sinuses for local medical treatment. So that's relatively easy. If you have to revise, then the question is, what are you going to do different this time? Is it just removing the polyps because they have grown back and you want to open up the sinuses again? Do you want to be more extensive in your surgery? But as Professor Hahn already emphasized, it is an inflammatory disease. Surgery is never going to cure the disease. Surgery is just making a new start, and the medical treatment, the anti-inflammatory treatment, has to keep the chronic disease under control. So the main uncertainty of surgery is, are you able to create a situation where the anti-inflammatory treatment can keep the disease under control? And if that's not the case, then the symptoms will come back.
And just in terms of that, Joseph, Wytske just mentioned you there. Anything that you'd like to add to what she's just said?
Yeah, I think, for me, when I do surgery, what I'm uncertain is how quickly the polyps are going to come back. And it's hard to determine, I think you have a general understanding by looking at certain lab results, but it's unclear, even if you do a perfect sinus surgery, it's unclear how quickly the polyps are going to come back. So there is a little bit of uncertainty for that. The other thing is, even if you also do a really great surgery, sometimes you're not sure how things will heal, because there are certain patients that make a lot of scar tissue, and there are specific diseases that have nasal polyps that after a good sinus surgery, it may look good for a couple of weeks, but after time you can develop extensive scar tissue and have problems. So those are certain uncertainties that you can't predict, even though you do the surgery well.
And Natasha, can I just come back to you as a patient? How much of this was explained to you about the risks, the benefits, the limitations of these various treatments?
Well, to be honest, the first doctor didn't give any explanation. I was one of those patients that went to surgery and thought that I was going to be cured, and that that surgery would be the end of all my problems, and that was not the case.
And what about, and just moving on to the biologics, how much of that was explained about the limitations, the risks, the possible benefits, and so on?
A lot more, but well, nobody can tell if it's going to work. It's all, every doctor says, yeah, well, we're going to try this and we're going to try that, and well, you don't know. No,
quite. And Daisy, for you, how much, rather like Natasha said, initially she wasn't really told very much at all. What for you was your experience? Was it explained to you, these are the certain risks, these are the benefits or possible benefits, these are the limitations, this might be possible, this might not?
Well, with the first surgery, I wasn't told either, but at the second time, they told me more, and then I was more prepared. I was still afraid, but I knew it must be there, the operation. But there was after the second operation, there was again hope that I was cured, but afterwards that wasn't the case. And then I was a bit depressed, but a biologic was more helpful. And then I knew that there was a part that, it was not sure that the biologics would help, but in my case, it helped me.
But how much did they explain about the biologics before you started them?
It was well explained.
Good.
Yes.
Excellent. Let me pause you there. Thank you very much indeed to our entire panel for those very insightful comments. Well, let's draw this to a close now. Very quickly, I really do want to get your final thoughts. Let's start with you, Daisy. What else can you add here based on your own experiences and indeed talking to other patients as well? What do you want people at home to know and to understand?
That they have to keep the courage to try the different treatments. It's not because the first treatment doesn't help, that the other ones won't help. Maybe it takes a while, but you have to go on and you have to try and again and again and again.
And Natasha, what would you like everyone at home to understand, having gone through the journey that you've told us about? What are your thoughts?
I agree with Daisy that it's a long road before you get there. And as a tip, I would say to other patients, ask as much as you can to doctors, because sometimes they forget to tell you things.
And that is a brilliant point. Ask as many questions as you possibly can. Let's now come to the clinicians. I mean, clearly, I think all of you have painted such a brilliant picture, a complicated picture. We talked about the individualistic approach that is needed. We talked about the geography, the drugs that may or may not be available. Joseph, Professor Hahn, your thoughts, having had this very eloquent conversation, how would you summarize what we've been saying?
So, what I've heard from Natasha and Daisy is that we as provider, as much as we know, we need to be able to convey a lot of the different, the risk, benefits, and limitations of the different treatment options that we provide to the patient. And I think, maybe sometimes we're not doing as good of a job. And even with a limited time, we need to be able to find a way to convey that information better to the patients.
And Professor Malol, your final thoughts.
They should know what are the stages of the disease, which treatment can solve stage to stage, and they should know the potential efficacy of drugs that are given, or the treatments, if it is surgery, the potential risk, the limitations, everything that we have discussed. But if I have to summarize, the most important thing that sometimes is lacking a lot is education and information.
Very well said indeed. Dr. Sharkey, your thoughts?
I think this was extremely educative also for me this evening, in particular because we have also the patient's perspective, not only from the surgeons and physicians. What I have learned and what I think is a priority is, as Professor Moyol has stated earlier, communication, and not only between patients and doctor, but maybe also between treating doctors as well. A second one is we have to face it, the resources are not unlimited. And this is a, let's say, call to action that we need to do more research to better understand with which treatment we can help which patients best.
Very, very wise thoughts indeed. And finally, if I may come to you, Wytske, Professor Fokkens, your thoughts, your concluding thoughts after what I think has been a very thorough conversation about where we are, the limitations of treatment, the benefits of treatment, and the role of the patient.
What I learned in this hour, and what I think is extremely important, is that for shared decision making between patient and physician, both need all the information available. And it's the task of the physician to be totally up to date, to be critical of what they can achieve and what they cannot achieve, to be honest to the patient, what can be done and what cannot be done in a chronic disease that will last for a very long time. And for the patient, it's so important to have reliable information and to really understand that information. And in the discussion in the outpatient clinic, we have to talk again and again. And if one discussion is not enough, we do it again. And if needed, a third time or a fourth time, until the patient is really the one who can take a learned decision. And I think that we need to do whatever we can to help our patients to become more knowledgeable and to manage themselves with our help.
Extremely wise words. Thank you to all of you. Now, just before we leave you, I do want to point out that there is a very valuable resource available to you. It's the EUFOREA Chronic Rhinosinusitis Pocket Guide and Treatment Algorithm, which includes options for both revision surgery as well as biologics. Now, EUFOREA also published an update this year on the practical guidelines for patients on biologic treatment, including criteria for the selection of patients who would benefit from biologics. It's incredibly helpful, it's very informative, and you can download it from the EUFOREA website. You can also scan the QR code, which is on your screen now. Well, sadly, that's all we have time for. It really has been a brilliant, thought-provoking debate. And many thanks indeed to all my guests for taking part, to Daisy Weinberg, to Natasha Seams, to Professor Joseph Hahn, Professor Joachim Mullol, Dr. Adam Scharker, and of course, Professor Wytske Fokkens. And thank you very much indeed to all of you for watching this EUFOREA Innovation Forum debate on how we use biologics and surgery to optimize outcomes for patients. I hope you found it extremely useful, informative, and provocative. And I hope what you've learned today, or indeed what's been reinforced in your own minds today, will be reflected in your own clinical practices. Now, you can find more information about EUFOREA and register for the EUFOREA meetings and eAcademy, the online learning portal, all available on the euforea.eu website. You can also sign up to receive the latest news via email, and don't forget to follow us on all socials for all the latest news and information. But for the moment, from all of us here, thank you for watching and goodbye. Thank you very much.